morning, everyone.
Good morning.
How are you?
Good.
All right. So my name's Hillary. I'm the Director of Prevention Services for High Point, and I'm the Director of the Brockton Area Prevention Collaborative. Who in this room has ever at any point done an overdose prevention naloxone training? Raise your hand. No one? A one? Okay. A couple people are kind of familiar with it. So we're going to go over the risk factors, signs and symptoms of an opioid overdose, and then we're going to talk about how to reverse an overdose with naloxone. So I run a team of 7, and we do prevention work throughout basically the greater Plymouth County area. We are based in Brockton. We work directly with the communities of Brockton, East Bridgewater, Whitman, Hanson, Rockland, Bridgewater, Plymouth, Middleborough, and Carver. And we do a whole host of different prevention initiatives, from underage drinking, prescription drugs, heroin, prevention, and we really work with the whole community. So I've done trainings for everything from early intervention to working with veterinarians to training the FBI. I've been working in this role since early 2010, so sort of before the opioid crisis kind of hit the point that it's at. In 2016, they estimate that over 66,000 Americans died of drug-related overdoses in the United States. That's far more than the number of people who died in car crashes. It's more people than died in the Vietnam War. So at this point, opioid overdose is the leading cause of unnatural death in the Commonwealth of Massachusetts and in many states across the country. That's been the case since the early 2000s, and more people have died of drug overdoses than in car accidents since 2012. So we're going to talk about recognizing signs and symptoms, risk factors, how to do a reversal, what not to do. So there's definitely a lot of information for us to get through. So, I kind of already talked about all this. We do public information. We actually, if you're anywhere on 24 South at exit 17, we have a big billboard up. We do a lot of work with the community. This training is based in harm reduction. Harm reduction is reducing harm in people who are unable or unwilling to stop using. High Point as a whole does education on many of the inpatient units and as well as with outpatient. We were one of the first treatment providers to do overdose prevention education for patients on the inpatient units. We've been doing that since about 2008, 2009. Patients here have access to naloxone, predominantly through pharmacy access. So if people come into treatment and they want to get naloxone or Narcan, they can access it while they're in treatment so that they can leave. We'll talk about why that's important. When you talk about addiction, we're talking about activating the reward part of our brain. Basically substances, they release our feel-good chemicals in this unnatural way, allows a feeling of euphoria for people to feel really good. It's an overstimulation of the parts of our brain that allow us to feel good. This reinforcing pattern creates a pattern that people will consistently need to use the drugs in order to feel normal. Otherwise, they'll go into withdrawal, and that's particularly the case for opioids. The brain attempts to basically try to regain its feelings of normalcy, which it's basically incapable of doing while they're still in active use. So the person doesn't experience joy or fulfillment or pleasure the same way they did without the substances. And the person will need more and more of the substance in order to get the desired effect, which is factors around tolerance. There's lots of risk factors for addiction. I'm not going to get too far into that because I'm here to talk about opioid overdose. So opioids are anything that comes from the opium poppy or anything that's synthetically manufactured by a drug company. That's chemical formula would mimic what you would find naturally occurring from the opium poppy. If you want to get technical, I think now people are a lot more comfortable with the word opioid, but when I first started, people didn't like that word. They preferred the word opiate. So technically, what's the difference between an opiate and an opioid? An opioid covers all naturally occurring, semi-synthetic and fully synthetic substances, so it includes everything from codeine, heroin, to fentanyl. An opiate only actually includes anything that has some natural derivative from the opium poppy, so those would be drugs like codeine and heroin, if you wanted to know. But it doesn't matter. Whether we use codeine or we use heroin or we use fentanyl or carfentanol, our brain can't tell the difference. It goes into our brain, it fits into our mu opioid receptors, and you would get a sensation from it. So you can't tell if someone's high on the effects of codeine or if they're high on the effects of heroin, the same way you can't tell whether someone's overdosing. You can't clearly define which opioid they're overdosing from. Predominantly when we talk about opioids, the only real illegal one, typically before the last few years, was heroin, and all the rest of them were pharmaceuticals, so they all had legitimate medical purposes. We use about 90% of the global supply of all opioids, and we use 99% of the global supply of hydrocodone or Vicodin. Vicodin is the most commonly prescribed drug in the United States of America, and oxycodone, which is the active ingredient in both Percocet and OxyContin, is the second most commonly prescribed drug in the United States of America. But other substances that are opioids, some are used in addiction treatment. Those are things like methadone and buprenorphine, which is the active ingredient in Suboxone or Subutex, as well as other pain medications like morphine or codeine, Dilaudid. I also think it's really important when we talk about opioids to really clearly explain the fentanyl sort of issue. So fentanyl is the most potent prescription opioid. In an outpatient application, you wouldn't see pills of fentanyl. You would see fentanyl in either a transdermal patch, kind of like a nicotine patch, or it comes in a lollipop. And that's really meant for someone who's in so much unbelievable pain that they can't even swallow pills. In an inpatient setting, so like in a hospital, fentanyl would be in a liquid form. It's, ladies, what we get in an epidural when we have a baby. It's used in the hospital all the time for surgical procedures. But when we talk about sort of the change in the game around opioid overdose and why it's gotten to such epic proportion, what we're talking about in that case around fentanyl is not about diverted pharmaceutical grade fentanyl, okay? We're not talking about some pharmaceutical companies selling that fentanyl on the street. We talk about fentanyl and how it's impacting us, particularly here in southeastern Massachusetts. We're talking about fentanyl that's made in rogue black market labs in India and China and are being sold through our drug cartels, particularly in southeastern Massachusetts, okay? And that fentanyl can be up to 5,000 times more potent than pure heroin, okay? So this stuff's deadly. Very small amounts of it are going to cause people to overdose very quickly, and they're going to need an enormous amount of naloxone to bring them out. Additionally to fentanyl, we have had 6 confirmed carfentanil purchases through law enforcement in southeastern Massachusetts, 5 of which of those had links to the city of Brockton. Carfentanil, in its pharmaceutical use, is used in basically in zoology. Okay, so it's used for very large animals. And I'm not talking about horses or cows, I'm talking about rhinoceroses and elephants. And legally, the entire United States of America can have 28 micrograms of carfentanil in the entire country to basically manage pain amongst animals in all of our zoos across the entire country. 28 micrograms. It's up to 10,000 times more potent than pure heroin. And it's being made in black market labs in India and China, and it's being sold in southeastern Massachusetts. Okay. And how that impacts overdose is that overdoses look very different in terms of their intensity, in terms of how quickly they can happen after someone's used, compared to if we were just talking about heroin or we were just talking about a oxycodone or Percocet overdose, okay? So I think it's really important to understand that, because as we talk about fentanyl so much in the media, I think a lot of times people think that what the fentanyl that's being sold on the streets are legitimate pharmaceutical grade fentanyl that's being diverted from pharmaceutical companies and sold on our streets, but that is not the case, okay? The other thing that we have that's very different from when I started is back when I started in 2010, if you bought a prescription pill on the streets, it was a diverted prescription pill, right? It was from someone's legitimate prescription. They were selling it, getting $1 a milligram for it. But now we've had a lot of issues in the last 2 years with prescription pills that are being sold on the streets that are basically pressed fentanyl, pressed heroin, pressed carfentanil. So people buy pill presses on the internet. They make up a mix, or they get a mix from some type of Connect, and then they press out the pills in their homes and sell them as diverted prescription pharmaceuticals. And where that's especially dangerous is, and we'll talk a little bit more about this, is that people who use prescription pills, if that's their drug of choice, they have a false sense of security with that pill to begin with, and actually are more apt to overdose than people who typically use heroin or cocaine combined, right? We have actually more fatal overdoses from prescription medication than we do from heroin and cocaine together. So these are all factors that have played into why we're here today, and why we're talking about all this. But I just wanted to start from an even playing field so that everyone kind of understands what we're starting with. So the depressants, in overdose, what someone actually dies from in an opioid overdose is respiratory arrest, okay? So basically what happens, see, I get ahead of myself sometimes. So opioids fit into our mu opioid receptors. I talked a little bit about that. It's like a perfect lock and key situation, okay? So if you think about it this way, opioids are like a key to the lock of our own brain receptors, and what they do is they release all of those feel-good chemicals in our brain at these ridiculously high levels. You can have any of 3 responses to using an opioid. If you're in pain, it sends a message for your body for you to be in less pain. It could bind to the wrong part of the receptor and you could get a really upset stomach, feel nauseous, vomit. The 3rd response is you get this deep, warm, euphoric sort of sensation. And you can have any of those 3 responses. It's not like you have one or the other necessarily. But what happens in an overdose is too many receptors are filled with too many opioids, and the brain can't send a message throughout your body to tell you to continue to breathe, okay? It's too busy processing the opioid, it doesn't send the message for you to breathe, and effectively what happens is you suffocate to death. So it's a process typically. However, it's crucially important that you guys understand that this is when we're talking about heroin and other prescription drugs. This is not the case necessarily when we're talking about that carfentanil and fentanyl. The carfentanil and fentanyl is so potent that someone can overdose very quickly and need a lot of naloxone. But when we talk about all other opioids, including heroin, you can have a delayed onset of up to 3 hours, okay? So that's kind of tricky if people think, well, I'm only going to overdose immediately after I use, and that this is going to be this process. That is very much the case if we're talking about an oxycodone overdose or we're talking about a heroin overdose. But if we're talking about fentanyl and carfentanil, someone can overdose very quickly and need a lot of naloxone to be revived. When you're talking about having experiences with patients, you don't know what someone did 5 minutes before they walked through the door, let alone 3 hours before they walked through the door. And let's say you're talking about prescription oxycodone, right? It's none of that black market stuff. It's just prescription oxycodone. And they've also mixed it with benzodiazepines, so things like Ativan, Xanax, Valium, and Klonopin. You can have a delayed onset of an overdose of up to like 8 to 12 hours, okay? It sort of takes a while sometimes for it to all hit someone. It's typically a slower process. You don't get enough oxygen to your brain, your liver, your lungs, your vital organs, and your body shuts down. So we used to say it was a very rare situation for someone to overdose so quickly that they still had a needle in their arm. But if we're talking about fentanyl and carfentanil, that absolutely can happen. It can happen very, very quickly. Anyone who uses drugs or alcohol can overdose, regardless of if they're a first-time user or if they're a veteran user. Now, the effects that opioids have on our body is kind of interesting in the sense that it doesn't necessarily degrade our organs the way alcohol or cocaine does. It doesn't have that impact. So a lot of times, people, the 2 primary reasons that people die from opioid use in particular are in complications from use, so things like HIV or hepatitis C, or overdose, okay? So theoretically, someone could use an opioid for a very long period of time and it wouldn't necessarily destroy all their vital organs. But what does happen is the longer someone uses, they sort of get this false sense of security. And people who've been using for a longer period of time are actually more at risk for having an overdose and from dying from an overdose than people who first start using. And there's a couple of reasons for that. In early use, people typically are a little bit more cautious about their use because they're a little bit more frightened or reserved, right? So maybe they don't know what they're doing, but they tend to be a little more cautious in their use. The second reason is the longer someone's been using, the bigger a tolerance that they have, right? So there's sort of more room for error there. And also, if someone's been using opioids for any period of time, they've developed a tolerance, they're not getting high the way they were when they first started using. So they tend to take bigger risks longer into their use than they did when they first started using because they've been going through all of this hell of trying to get the drug and use the drug before they go into withdrawal and they're not really getting high very frequently, they tend to be less cautious and they tend to take much bigger risks. So that's some of the behavioral components of substance use when it comes to opioids in particular. So we talked a little bit about this. There was, in 2016, a confirmed number of 2,069 fatalities in Massachusetts. I would beg to argue that that number is probably low by 10 to 20% based on how they code overdoses. About 8 people die every day in the Commonwealth of Massachusetts with a population of 6.6 million from opioid overdose. In Plymouth County, where we are currently, ranks amongst the highest for opioid overdose fatalities in the state. So we talk about harm reduction. We talk to our patients and clients about how to use more safely if people are unable or unwilling to stop using. And that's a longer training that we do. But it's important to understand what puts someone at risk for an overdose, okay? Typically, right, people are not trying to overdose. People who are trying to overdose, that's called a suicide. But a lot of times what happens in overdoses, it's not an intentional thing. It's that a lot of little factors sort of play one into the other that puts someone at risk for an overdose. So one of the biggest things that we're seeing, particularly in this area, is mixing of substances will obviously increase someone's risk for an overdose. When we put multiple substances into our body, we tend to rationalize it like we're adding one thing to the next. But in actuality, what you're doing is you're multiplying each and every substance you take one to the next, okay? So it's very common amongst people who use opioids for them also to use benzodiazepine. So again, Xanax, Ativan, Valium, and Klonopin. They quell withdrawal symptoms. They're also central nervous system depressants. They also impact your ability to get oxygen. Alcohol is also commonly misused with opioids. It's a certain population that uses stimulants like cocaine or crack cocaine or even things like Adderall or Focalin or Concerta. But the street theory behind using an upper and a downer at the same time is that you're going to level off somewhere in the middle. What you're actually doing when you use an upper and a downer at the same time is it's like plugging your nose and shutting your mouth and running a 200-meter dash on repeat. You're actually 8 to 10 times more likely to die of an overdose if you speedball than if you just were to pick one substance over the other. There are also substances that sort of like in and of themselves you wouldn't get all that high from, okay? But when mixed with opioids, they act like amplifiers. So those are things like gabapentin or Neurontin, Soma, baclofen, phenergan. They can amplify opioids, and you see a lot of mixing of those substances because they might be easier for people to get their hands on, and they're definitely cheaper. So one of the big reasons why we started doing the training for folks who are inpatient was truly, I think the mission of High Point is to provide supports and services to individuals who are struggling with substance use disorders and mental health, mental illnesses. But one of the most crucially important things is to keep our patients alive so that they can come in and they can try a chance at recovery again, right? And you can't work on your recovery if you're dead. So as much as it was hard when we first started to talk about harm reduction and to talk about naloxone, 10 years ago, back in the early days when no treatment providers were doing this, the reason why it was so critically important is that when individuals come into an inpatient treatment setting, they're by definition dropping their tolerance, okay? And your tolerance can be impacted to the point that it will increase your risk significantly for an overdose as quickly as 1 to 3 days of not using. So you think about it, you come into a 5 to 7 day detox. Maybe you go on to CSS for a week and a half. Maybe then you go on to TSS for 2 months. Or maybe you come in for a 17-day Section 35 that you weren't exactly planning on. Your tolerance is dropping every single day that you don't use. And when you leave, we know that relapse is part of early recovery. If you leave and you pick up, your risk for an overdose has just increased significantly. So it was so important for us to talk about overdose prevention, to give access to naloxone to our patients, because sort of by definition of them coming into treatment, they were going to drop their tolerance, and therefore their risk for overdose, and potentially a fatal overdose, has just increased significantly. Does that make sense, guys? Right. So 1 to 3 days of not using. Every day you don't use, your risk for an overdose will increase. And then that also plays into typically people are using the same sort of connect for them to access drugs, but like, we also know the whole concept of a geographical cure, and it might work for some people. But if I've gone into treatment and I've been in treatment for 2 weeks and I get out, the stuff on the street could very easily have changed significantly while I was in treatment, okay? And if I'm going into treatment in one location, let's say I'm from Brockton and I end up in treatment in New Bedford, and then I go and I'm trying to pick up in New Bedford, geographically, heroin is very, very different. So if I buy heroin in Brockton, it's going to be very different than if I buy it in Plymouth, and very different if I buy it in Taunton or Middleborough, okay? So there's very much a geographical context when you talk about street drugs. And from town to town, and in some cases from one end of the city to the next, what you're going to get could be very, very different. So that goes into that like quality control fluctuations within purity. The State Police Crime Lab has tested heroin in Massachusetts as low as 5% pure and as high as 95% pure, and that's before you add in the fentanyl or the carfentanil. And to be honest with you, in southeastern Massachusetts, more and more frequently, when they do sort of like field testing on drugs, they're not finding any heroin in the cuts at all. All that's in there is some form of a fentanyl analog. So that fluctuation in purity is tremendous. And again, like we talked about, those pressed pills also, that's a significant change in the purity, because if you think you're getting a diverted prescription pill and what you're actually getting is a pressed pill with God only knows what in it, it's definitely a significant factor. Physical health is a really crucial risk factor for individuals, and it's not one that we often necessarily think of. So because an overdose is respiratory arrest, anything that negatively impacts a person's ability to get oxygen when they use will increase their risk for an overdose. So that could be a cold, a cough, a flu, bronchitis, COPD, seasonal allergies. Also, when people are in active use, they typically are not taking very good care of themselves. So they're not eating properly, they're not sleeping well, they're not getting enough fluids. Well, that equates to a body that's exhausted, dehydrated, and malnourished, okay? It's not the same as it was when it was more healthy. We tend to see fatal overdoses increase in the summer months, and that's because heroin toxicity increases in a dehydrated body. Now, the physical health component is not an equal opportunity sort of employer in this, meaning that it impacts women differently than it impacts men. So ladies, we actually have more mu-opioid receptors in our brain for us to be able to accommodate for childbirth, which means sometimes you can find these tiny little women who weigh like 85 pounds and are like 4'10", and I've never been that, not a day in my life. But those women sometimes can have very high tolerances, okay? But if that woman loses a pound or two, that's a much significant portion of her body weight than a 6'2", 200-pound male. Do you get what I'm saying? So weight loss and sort of the rundown body negatively impacts women disproportionately. Also, if we're talking about intravenous use, there's a lot of complications with that. So things like abscesses, infections, endocarditis, things like cotton fever even. When the body is trying to fight all of those infections off, and it's just not the same as it is when it's more healthy, it increases someone's risk for an overdose. Hepatitis C, which is also very common amongst IV drug users, increases someone's risk for an overdose because Hep C impacts our liver, which is the filter for our body. So though someone's not necessarily feeling the impacts of using several days prior, that doesn't mean that the body's actually been able to filter that out of the system. So it sort of can add one to the next. Also HIV, with the effects that it has on the person's immune system, can increase someone's risk for an overdose. If someone's overdosed in the past, they're at risk of having a future and of having a fatal overdose. And the reason for that is it's not necessarily that you've damaged your brain or you've damaged your body, okay? A lot more of what it has to do with is that behavioral component to overdose. So most people are afraid to overdose, okay? And then once they have, they've sort of subconsciously, and I don't think anyone thinks about it, they've gone through this barrier of fear, okay? And then in the future, they tend to maybe be sort of a little less cautious in their use. So it is important to know that if you've had a previous overdose, you're at an increased risk of having a future overdose. I work with the local hospitals up in Brockton, and at one point in a span of like 30 hours, we had a single individual overdose 6 times. So overdose, like almost chronically overdosing, is definitely a real thing. Overdose clusters are very much a real thing. What an overdose cluster is, and it's really important that I mention that in a clear, rational, sober mind, this doesn't make any sense. But in the throes of active addiction, when someone hears that someone has died of an overdose, they're going to go and try to find that connect. They're going to go and try to find that stuff. Because it's not that it reads dangerous to that person, like I should stay away from it. What it reads to that individual is that's the good stuff and I need to get me some of that. So we see those very clearly in a lot of the communities that we work with. About 18 months ago, we had 26 overdoses in one of the 2 Brockton hospitals in 24 hours. Okay, 2 of them were fatal. So overdose clusters are very much a real thing. Typically, when we go through death certificates, we find a lot of them clumped together in a very short span of time. So recognizing the signs and symptoms of an overdose on any depressant. Okay, so like I said earlier, I couldn't tell if someone overdosed in front of me. I couldn't tell the difference of whether they overdosed on codeine or fentanyl. But additionally, someone who's overdosed on a benzodiazepine, so again, Xanax, Ativan, Valium, Klonopin, or someone who is overdosing on alcohol, they're all going to look the same. With the one sort of outlier of if someone's overdosing on alcohol, you'd be able to smell the alcohol in the individual. But they can have any of these symptoms. So I want to go from the least obvious to the most obvious. So the most confusing sign of a depressant overdose is that someone could actually still be up, walking, or talking. Now they can't look you in the eye and engage with you, and they're likely walking into walls or furniture. But someone does not have to be passed out on the ground to be in an overdose. They can still be up, walking, and talking. And the problem with that person is it's human nature for us to write that person off and to be like, they're still walking, they're still up, they're fine. That person will go unconscious, and when they do, they're actually further along in the overdose than if they were to just go unconscious to begin with. So we'll talk about how to kind of engage with that person and make that determination in a minute. The most obvious sign of an overdose is a blue tinge to the lips and to the fingertips. In someone who's pale like I am, you might be able to catch it at the tops of the ears. The darker the complexions are, the darker those features are going to be. So in someone who has very dark skin, their lips might be pure black. Their fingertips would be pure black, okay? So it's a drastic change in that person's coloring. Otherwise, their face is typically going to be very gray, pale, or ashen. If you were to touch their skin, it would feel super kind of cool and clammy. Their pulse and their breathing is going to be slow, stopped, or erratic. They could be foaming at the mouth. If it was an Ultram or Tramadol overdose, which naloxone is only partially beneficial in, and we don't see those all that often, they kind of come in waves. Someone could be having very severe seizures, but that's typically only in Ultram and Tramadol. They could be passing out. They could be foaming at the mouth. They could be making this really deep, exaggerated, snoring, gurgling type of sound. We call it the death rattle. A lot of family members have been able to revive individuals because they can hear that. It can be so loud that it wakes someone up in the next room. So you can be doing any of these things in any combination. Whereas when someone's really high, they kind of look similar, but there's some key differences. When someone's really high, their muscles are relaxed, their speech is slow and slurred, they've got that all too familiar nod. In an overdose, someone's nod can be so exaggerated, they're practically going to the floor and coming back up. They're sleepy looking, but the big difference between someone who's in an overdose and someone who's just really high is someone who's really high will respond to stimulation. Another key point about someone who's really, really high is, and let me tell you, I do an enormous amount of work with law enforcement, and this was revolutionary to the cops, is that someone who's really, really high, they might look like they're asleep, they might look like they're not paying attention to you, they can hear every word you say. And when they sober up, oftentimes they will remember everything you had to say. So don't say something in front of someone who's really jammed that you don't want them to hear, because they likely will remember it. But in my years of doing this, I've learned some sort of tips and tricks. One of the things that I've done quite frequently is if there was someone that I thought was overdosing, and I didn't get to the point that I did the sternal rub, but we'll talk about that in a minute, what I would do is say, if you can't respond to me, I'm going to have to Narcan you. And it's almost a textbook reaction. You get someone who's not responding to you, not in full out, and you say, I'm going to Narcan you, and it's like 2 feet go flat on the floor, shoulders come up, head comes up, eyes come wide open, and all of a sudden the person can engage in a conversation with me. Now, if you say to someone who uses opioids that you're going to Narcan them and you get no response, or the response you get is like a swatting, you probably want to move on to the next steps. And what we recommend is the sternal rub, which is your knuckles up and down on the person's breastbone or below the nose and above the upper lip. It's a super uncomfortable bone-on-bone action, and if they don't respond to that, it's pretty safe to say they're in an overdose. Depending on what your role is, I always recommend looking at information from this and seeing how you can utilize them as teaching moments. So let's say, for example, you're doing an intake with someone and you say, hey, have you ever overdosed in the past? And they say, no, I absolutely never have. And you're looking at a black and blue sternum, they're probably not being honest with you, okay? But if you do the sternal rub on someone and they don't respond to you, and you've told them you're going to Narcan them and they still don't respond to you, it's really safe to say that they're in an overdose. So, what to do? Overdose management is really a process with some key steps that are best to be done in a particular order. So we've gotten up to stimulation. The next thing to do is to call 911. Now we all have cell phones on us, and I appreciate, and maybe it's because the camera's out, that none of you guys are on your cell phones, and it's really easy for us to just pick up our cell phone and call 911. Has anyone ever called 911 from a cell phone? Okay. I just had to do it on Friday because I witnessed a car accident. When you call 911 from a cell phone, who do you get? God only knows. It's the state police. It's the state police. And actually, in both cases that I've ever called 911, when I've called 911, I was kind of like right on the border of two places, right? So I'm like in the car in between two towns. So you go to the nearest state police barracks when you call 911, and then you have to wait for them to transfer your call with the likelihood of that call getting dropped, okay? And you're wasting crucial time where someone's non-responsive and not breathing. So the number one recommendation when we talk about calling 911, really in any situation, but definitely in an overdose situation, is even if it takes 15, 30 extra seconds to get to the landline, call from a landline. Because when you call from a cell phone, when it eventually goes to your 911 dispatch, what eventually populates on the screen for the dispatcher is first and foremost the billing address of that cell phone, and then secondly, your nearest cell phone tower when it gets pinged. But that's not an automatic thing, and probably a lot of us don't even buy cars with navigation anymore. Who the hell uses a TomTom or a Garmin anymore? We use our cell phones, and so we think because we're using our cell phone that they know exactly where we are. They don't. But when you call from a landline, what does populate on the dispatcher's screen is a nice little Google map with a nice little red balloon. So even if it takes 30 seconds longer, in any situation, call from a landline. It'll save time in the long run. On August 2nd of 2012, the Good Samaritan 911 law was passed in the Commonwealth of Massachusetts, and that gave two primary provisions. The first is that if you called for help in the event of an overdose, that when the responders came, that anyone who was on the scene, the person who overdosed or any sort of Good Samaritans or individuals who were there, they couldn't be charged with possession or conspiracy to violate drug laws. So the provision is that you are basically given limited immunity for pretty much any sort of low-lying drug charges unless you have enough drugs to be considered trafficking or unless you have a warrant out for your arrest. And then again, it's going to be at the discretion of the responding officer. And every community is different, so plenty of communities don't send law enforcement when you call in for an ambulance, and some do. So it depends on the situation. The other thing that the Good Samaritan 911 law said is if you provide naloxone to someone in good faith, you're not at risk for any type of liability. So someone can't sue you because you gave them Narcan. And we'll talk a little bit more about why that is with Narcan. So the reason that law was passed was because in every community people were afraid to call for help in the event of an overdose because they didn't want to get arrested. So, like I said, again, it varies community by community, but it's definitely saved a lot of lives. If you have to leave the person for any reason, you would put them in the recovery position. Otherwise, what you would want to do first is call 911 because you want EMS en route. You want them in the ambulance coming towards you. You don't want to administer Narcan first. You want to call 911 first. But then you would do rescue breathing and administer Narcan if you have it. So when you call 911, stay calm, have the address, tell the dispatcher the person's not breathing. Years ago, people used to make up these horrible things because they didn't want people to waste their time and dawdle and not come, but hopefully with the Good Samaritan law, people are just calling right away and saying someone's non-responsive, they're not breathing. The first responders are going to come with naloxone. In pretty much all of Plymouth County, law enforcement carries naloxone. So if they were the first on the scene, they could provide naloxone to the individual. If you have to leave the person for any reason, you have to grab the phone, you have to grab the naloxone, you want to leave the person in the recovery position, which means you put them on one side. It really doesn't matter what side. There's all these old wives' tales. Unless someone has had a stroke or has had some type of significant injury to one side of their body, it doesn't matter what side you put them on. You want to support the head, mouth open and pointed downward, cross the leg over the body. It acts like a brake and prevents that person from rolling back onto their back or onto their stomach where they could choke on their vomit or whatever. So put the person in the recovery position if you have to leave them for any reason. You would do rescue breathing after you've called 911, which is while the person's flat on their back. You're going to look in their mouth, and if you see anything in their mouth, you're going to use your pointer finger like a hook, and you're going to pull it out. Once the airway is cleared, tilt the chin, pinch their nose, put your mouth over theirs, give them 2 deep, slow breaths. You want to see the chest rise and not the stomach. If you see the stomach rise, you probably haven't tilted the chin up far enough. You'd give the person 2 breaths before you'd administer naloxone. If you did not have naloxone, you would continue giving 1 breath every 5 seconds, either until help arrived or until the person started breathing on their own. There are 2 things that are beneficial in an opioid overdose: oxygen and naloxone. That is it. So even if you don't have naloxone, but you have the ability to rescue breathe for the person, you will help them to survive. There's a lot of talk about barriers or I'm not breathing for the person. A lot of times people who work in nursing staff, I say if you're familiar with that and you want to go or for anyone and get a mouth barrier, they're like less than $1, put it on your keychain, you can have that. Typically what we say in the field is a single layer of clothing, like a t-shirt, is usually enough of a barrier to prevent things from going through. I've definitely worked with people who said, listen, if I don't know that person, I'm not doing mouth-to-mouth on them. And I would say that's your own personal decision, but you might make a different decision if someone was actually lying in front of you purple, not breathing. So that's sort of rescue breathing. Naloxone is something that can speed up the process, but still does require rescue breathing so that you're getting oxygen to the person's brain and to their vital organs. Notice I didn't talk about compressions, I did not talk about CPR. They're not necessarily beneficial in a respiratory arrest situation, and typically someone does have a pulse. The other thing is my CPR has been expired for a decade now, so I'm definitely not teaching anyone about CPR. Because in an overdose, really, it's rescue breathing and naloxone that are the most impacting. So, I keep saying naloxone, and you're probably more familiar with Narcan. The reason I say naloxone is Narcan as a company, and obviously I've got issues with the pharmaceutical industry as a result of the whole opioid crisis, but basically the company that owned the name Narcan, which is what this bad boy is, they kind of went dormant for a number of years, and what we were predominantly using was the 2 configuration. If anyone's seen that you screw everything in. That was a generic. So there are different types of naloxone, but these guys they kept the patent and the name, but when the opioid crisis was sort of first picking up, they didn't do anything, and then they came out when there was money to be made, and I don't love that situation. The other thing that I don't like necessarily promoting, but it does exist, and if your insurance would cover it and it would make your life easier, is, has anyone seen or heard of the auto injectors? So they have an auto injector. It's kind of like an EpiPen. It's like this little square thing, and you pop the bottom of it up and it talks you through it, and it's an auto injector. I don't like those people either, because when they first released it on the market, they charged $500 a dose. A lot of money. Well, it gets worse. So like 18 months ago, a year ago, all of these people are dying in the United States. They say, we're not making enough money from it. We're going to charge $6,500 per dose. Now, with some commercial insurances, so depending on what your private insurance is, you might get a $6,500 instant coupon, and your insurance might bill it for free because of some type of negotiated rate. So there are basically on the market 3 different types. There's the 2-step generic that you would screw in, 2 mLs per 2 milligrams. That's kind of gone obsolete because we now have more potent versions of it, and it takes a little bit longer. Predominantly what you're going to see is this guy, and in any time that you would get a naloxone prescription, or if you were to fill it through a pharmacy, or if you were to go to a pilot program, you're mostly going to see this, and you're going to get 2 of them. I think with the auto injectors you would get 2 as well, but this is predominantly what you're going to see. So what naloxone does is it's a complete opioid antagonist. It's used solely for the purpose of reversing the effects of an overdose. It's safe and effective. If you give someone intranasal Narcan and they're not overdosing, they're having some other form of respiratory emergency, you can't hurt that person. All you're going to do is give them a runny nose. They've had a very, very, very low incident of individuals who've had any type of allergic response to it, and the vast majority of that has been a skin rash, and they've had no known cases of anaphylaxis as a result of Narcan. And the best part is like, you can't actually kill a dead person, okay? So if you administer Narcan to someone and that's not what's going on, you can't kill them any faster with this, okay? So what Narcan does, so that's the old version, the 2 milligrams and 2 milliliters, and this is the newer version. I'm trying to see if I have the picture. Okay. What Narcan does is it goes into the brain, and it has a greater draw to the opioid receptor than the opioids do. So basically what it does is it pops the opioid off the receptor, and it binds to that receptor, blocking the opioid from going back into the receptor for, we used to say 30 to 90 minutes, and if we were talking about oxycodone or we were talking about heroin, 30 to 90 minutes still sounds like a good number. But because there's so much fentanyl and carfentanil and stuff out in the market in this area, we're saying that the half-life of Narcan is only about 20 minutes right now. And it's sort of like if you give someone an EpiPen, they need further medical intervention. It's very much so the same case with naloxone. It displaces the opioid in the brain. It does not dissolve it, okay? So it's still very much floating around in the brain, and the person could re-overdose. So like I said, it's safe and effective. There's no potential for abuse. You can't get high off this stuff. Narcotics dog handlers, officers who handle narcotics dogs carry naloxone. They use it on narcotics dogs with some level of frequency. So the kind that we're talking about predominantly is the intranasal. So it's absorbed through the mucous membrane in the nose, and it goes directly into the person's brain. Medical responders, so EMTs, paramedics, nurses in the hospitals, they could also give it to you intravenously or intramuscularly. And that's really, that auto-injector is obviously an intramuscular shot. So it's safe and legal for you to carry. There's just been a huge call from the government to increase access to naloxone across the country. We have fairly decent naloxone access. We've had it in the state of Massachusetts since 2006. But nationwide, they're calling for better access to it. Now, someone likely, unless they're overdosing on oxycodone, if someone has any of the fentanyl or carfentanil in their system, they're likely going to need several doses of naloxone. So you call 911, you rescue breathe for the individual, those 2 rescue breaths. Then you could administer your first dose of naloxone. If you don't see improved signs of life, what I mean is better color, better respiration, after about 30 seconds, which is going to feel like a long time, you're going to want to go back and do more rescue breathing, 1 breath every 5 seconds, until you hit about 3 minutes. at the point you hit about 3 minutes out, you could administer a second dose of naloxone, and you could continue doing that. There's no such thing as giving someone too much naloxone. And we've had many cases in the local area where someone's needed 10 of these, okay? You're only going to likely at any point in time have 2. So what you want to make sure you're doing is breathing for the person in between. If you were to administer 2 doses to someone back to back, effectively what you're doing is you're creating too much competition in the brain. It doesn't have a chance to settle, okay? So you want to wait about 3 minutes in between each dose. Now, when the opioid is no longer in the brain receptor, my staff think they're being cute with all these animations, but they're not. When the opioid is not in the person's brain receptor, that person has any tolerance. They're going to go into deep and immediate withdrawal. And the last thing they're going to remember is being really high. And now all they know is they're super sick. And they have no idea what happened. Anyone who's ever been Narcan in the history of the world is going to tell the people who Narcan them that they didn't need to Narcan them, that they overreacted, that that was excessive, right? They don't know that they were purple, non-responsive, and foaming at the mouth. So it is a pretty typical response when someone has been given naloxone, to the point when we first started doing this, a lot of people who had opioid use disorders, they hated this stuff. And it's like, well, this just brought you back to life. But the withdrawal will wear off when the Narcan wears off, and that could be, about 20 minutes. So when the Narcan wears off, the person needs to be at the hospital because they're typically going to have one of 2 responses after that. They're either going to be really high again or they could re-overdose. So I think the protocol right now is for emergency rooms to keep the person for about 3 to 4 hours. But if you think about it this way, different opioids have different half-lives. So if someone, say, was overdosing with methadone, they're going to really need to be monitored very closely for like 24 hours because of how long methadone lasts in the person's brain, okay? But that's how it works. It's really easy. You spray it up the person's nose. These ones are one-shot wonder, to the point that they don't even give us trainers. If I were to take this out of the package, it would just spray right up. I do recommend if you do get Narcan, you can peel back part of it so that it's slightly easier to access. You don't want to take it completely out of the package because it's very trigger sensitive. So like if I had this in my purse, it would end up spraying all over the place. It's meant to be kept at room temperature, 59 to 86 degrees. That being said, plenty of people do keep it in their car where obviously, for example, now in April it could freeze or, get too hot maybe at some point if we ever see summer. But it can still be effective. Best case scenario is room temperature. It has about a 2-year shelf life. At that point, honestly, expired Narcan is better than no Narcan. I would never throw it away, but you can go and get more. You can get it free through different pilot programs. In Brockton, we have the COPE Center, which is an amazing resource for all types of harm reduction and different services. Family members, loved ones, and friends can get it through Learn to Cope. They'll train you in it. They'll go over it with you, or you can tell them you've done the training. They'll give it to you for free. The other way you can get it is through local pharmacies with a standing order. So you don't actually have to have a prescription. You can just go in and say, I'd like to get naloxone. They're going to bill your insurance, okay? So it's going to depend on what your insurance is as to what your copay is. It might be a few dollars. It might be $20. I don't have it with me, but if you're up in the Brockton area, we have a list of all of the vetted pharmacies that we use. Walgreens has said that they're going to have it in all 8,000 of their stores. CVS carries it. Hopefully they're treating you nicely when you're asking for it. You don't need a prescription. It doesn't need to be for yourself because you're not going to Narcan yourself. That's not how this stuff works. If you ever don't have a positive interaction, let me know because we're working to capture that. What not to do in an overdose situation. Now, I'm positive that none of you guys are going to do any of these things, but it's important to know what the word on the street is. So when we first started doing this, it was as important to engage the community and get the facts about what to do as it was to combat street theory. And there's a lot of street theory when it comes to drug use because it's not like they hand out an encyclopedia or a user's guide, right? And all it took was one person to say this works, and then it sort of passes like wildfire through the community. So obviously you don't want to leave someone alone in an overdose. They could stop breathing. And again, we're talking about depressant overdoses, so alcohol, benzodiazepines, or opioids. You don't want to put them in a bath. When I first started in Brockton, we didn't know how we were going to impact the community or what was going to happen. And what was amazing was within a few months, what we started to hear was the number of overdoses going into the emergency room had actually gone up. But what had gone down was the number of people who came into the hospital soaking wet. Because it was a street theory, or it is a street theory, that if somebody's overdosing, toss them in a cold shower, toss them in a cold bath. And normally what would actually happen is you take the individual who was blue, you put them in a cold shower, and now you've got someone turning purple pretty quickly. And it's a threefold bad idea. You're going to drop the person's body temperature, which you're actually going to increase how quickly that person's dying. You're going to get water in their nose and in their mouth. There's no way to avoid it, so now you've got someone who's suffocating and drowning. And then the third thing is you've got a soaking wet, completely dead weight, full-grown adult that you're trying to get out of a bathtub or a shower, and it's like a game of tug of war you just don't want to play. Sort of same thing in the winter or in April at this point. Toss them in a snowbank or out in the cold. It will increase how quickly that person's overdosing, so you don't want to do it. You don't want induced vomiting in someone who's taken too much of a depressant. The issue is in their brain. It's not in their stomach. You're just going to increase their likelihood of choking, and it's not going to help the person. Don't give them anything to eat or drink. Again, alcohol, benzodiazepines, or opioids. If someone does not have the capacity to take a cup, bring it to their mouth, and put it back down, they should not have it. Because they can either choke as they try to swallow it, or they can throw up and then choke. And we don't want that. Don't put ice down their pants, underneath their armpits, up orifices. This was like a real thing people were doing. Terrible idea. Again, we're going to drop the body's temperature and increase how quickly the person's overdosing. Don't stimulate them in any way that could cause harm. Don't hit, kick, slap, punch, or burn. 20 years ago, guys, which was 1998, if that doesn't make you want to throw up, legitimate programs would tell people to burn someone, like take a lighter to their hands or to their feet to try to pull them out of an overdose. It's a terrible idea. But again, if we're talking about teachable moments, if you found someone who had fresh burn marks on their hands or on their feet, you might think it's self-injurious behavior. It could have been that someone heard that that works to pull someone out of an overdose. Don't inject them with anything at all. So I don't know what it is with the IV drug using community and like the movie Pulp Fiction. It's like peanut butter and jelly, okay? So for years at Batsy, I did all of ATS and all of CSS together every week to do overdose prevention for people who, with the harm reduction component to it. And I never once in 3 years didn't have someone come up to me at the end of the training and say, I got Narcan, it was a needle, it was like this big, and it went directly into my heart. And I was like, no, that's not what happened. That you've seen Pulp Fiction one too many times. You have no idea what happened to you when you overdosed. You were given naloxone intravenously, intranasally, or intramuscularly. But these are these like Pulp Fiction theories as to what works in an overdose. So sugar water, I guess, is supposed to stimulate you out of an overdose. So you take a depressant and you take a stimulant and you're going to level off somewhere in the middle. It's a terrible idea. As someone's body shutting down, you give them all that sugar, they can go into like a diabetic shock situation. Mountain Dew, Coca-Cola, again, that's the same theory. If you could imagine putting Mountain Dew in someone's veins and the complications that that's going to cause, that is a street theory, that does happen. Salt water is a street version of saline. I think the theory is that you'll dilute it in the bloodstream. But in someone's body who's not getting enough oxygen, you give them salt water, you're going to change the electrolyte balance in the person's body. And so not only are they suffocating, they're also probably going to go into cardiac arrest. Cocaine, same thing. You're going to give them a speedball and increase their heart rate while they're not breathing. It's a terrible idea. But those are all things that people do in a pinch, in a street situation. People believe them to be true, and so it gets kind of perpetuated. So they're all bad ideas. And then obviously don't let someone sleep it off or wait it out. They could suffer serious brain damage or die. Okay, so I've talked a lot. We are located on the Meadowbrook campus. Me and my team, and then one of my staff members is down in outpatient on School Street in Plymouth. We have an award-winning website, opioidoverdoseprevention.org. We also are all over Facebook, the Brockton Area Prevention Collaborative. We have a lot of information, trends, all kinds of things that are going on within the communities we work with. So, thank you. Thank you. I appreciate that. And maybe we can shut this off and I can take any questions. So the deal is that I will let them film me, but I don't, as long as I don't have to watch it. Right? That's like a fair deal, right?